Let's discuss omphalocele, a congenital condition involving the abdominal wall. An omphalocele occurs when abdominal organs such as the intestines, liver, and sometimes other structures uh, fail to return to the abdominal cavity during development. Instead, these organs remain herniated into the base of the umbilical cord. A key characteristic of an omphalocele is that the herniated organs are covered by a membranous sac, uh, which consists of two layers, amnion on the outer side and the peritoneum on the inner side. This protective sac differentiates omphalocele from other abdominal wall defects such as gastroschisis, which we will discuss later. To understand omphalocele, let's briefly review its developmental context. During normal fetal development, the gut temporarily herniates into the umbilical cord between 6 to 12 weeks of gestation. This occurs to accommodate the rapid growth of the intestines. By the end of the 12th week, the gut undergoes a process of rotation and returns to the abdominal cavity, completing the normal developmental sequence. In cases of omphalocele, this process does not occur as expected. The abdominal contents remain herniated uh, beyond 12 weeks of gestation, resulting in the persistent presence of organs outside the abdominal cavity, enclosed in a protective membranous sac with a cord insertion on top of this mass. This failure of midgut rotation is what underlies the condition we observe clinically as an omphalocele or exomphalous major. When diagnosing omphalocele using advanced ultrasound techniques, both 3D and 4D ultrasound play pivotal roles. With 3D ultrasound, we can achieve detailed surface rendering of the omphalocele sac. This enables us to clearly identify the contents, such as the intestines or liver, and assess the context of herniation. Additionally, 3D imaging is particularly valuable in differentiating omphalocele from other abdominal wall defects, such as gastroschisis, with lack of protective membranous sac. On the other hand, 4D ultrasound provides dynamic real-time visualization. This allows us to observe fetal movements and better understand the relationship between the herniated organs and adjacent structures, offering essential insights for planning and postnatal management. Together, these modalities enhance our ability to evaluate and manage this condition with greater precision. Omphalocele is a midline abdominal wall defect where abdominal organs herniate into a membranous sac at the base of the umbilical cord. One of the key distinguishing features is the presence of this membrane, which differentiates omphalocele from gastroschisis, where the herniated organs are exposed without a covering. The content of the sac can vary. While intestines are commonly involved, larger defects may also include the liver or other abdominal organs, such as stomach maybe. The presence of the liver within the herniation is an important prognostic indicator, as it suggests a more significant defect. Beyond the structural anomaly itself, omphalocele is frequently associated with additional congenital conditions. These include major cardiac defects, chromosomal abnormalities such as trisomy 13, 18, and 21, and syndromes like Beckwith-Wiedemann Syndrome. Therefore, a detailed evaluation using advanced ultrasound techniques, including 3D and 4D imaging, is crucial. for assessing the context of the extent of the defect and identify associated anomalies. Crucial part of diagnosing omphalocele is differentiating it from physiological midgut herniation, which is a normal developmental process. In physiological midgut herniation, the bowel herniates into the base of the umbilical cord between 6 and 12 weeks of gestation. These herniated loops are relatively small, involving no covering membrane and do not include other organs. Importantly, this is a temporary process that resolves spontaneously by the end of the 12th week. On the other hand, in omphalocele, the herniation persists beyond 12 weeks and is more extensive. It may include larger structures such as the liver in addition to intestines. The herniated contents are also covered by a membrane, which is a distinguishing feature of omphalocele. Recognizing these key differences helps us avoid misdiagnosis and ensures accurate evaluation during the critical first trimester period. The management and prognosis of omphalocele require multidisciplinary approach, beginning with prenatal care. Serial ultrasound evaluations are essential to monitor fetal growth, amniotic fluid levels, and any associated anomalies that may influence the course of the care. Delivery planning is critical for large omphalocele. A cesarean section may be recommended to minimize the risk of sac rupture during delivery. Postnatal care involves surgical intervention. The goal is to close the abdominal wall defect, which may be done immediately after birth or in stages, depending on the size of the defect, of course. For larger omphalocele, stacked repair using a silo placement may be necessary to gradually reduce the herniated organs into the abdominal cavity. Prognosis varies significantly. Isolated omphalocele tend to have a better outcome, but cases with associated anomalies such as chromosomal defects or cardiac abnormalities may face more challenges. So accurate prenatal assessment and timely surgical intervention are key to optimizing outcomes.